Hello, guys. So I just told you I want you guys to take a break and allow your minds to melt a little bit. I'm actually gonna figure out something real fast. Never mind, you'll have to see my cat and everything that goes with it. Alrighty, so we're gonna talk about the urinary system. So 12th man, I always like to show. 12th man is our kidneys. They're located at the level of the 12th rib. They're located retroperitoneal, which means they're behind that mesentery, behind the peritoneum. And they're located, a lot of people think they're located way low in their lower back, but it's actually in the mid back where these guys like to ride. You have two of them. Some people are born with more than two. Some people are born with one, and some are born with something called a fused kidney. We'll learn in embryology what that does, but these two kidneys fuse together to become a horseshoe kidney. So what do the kidneys do? They regulate the total water volume and total solute concentration of water. And solute means salt, glucose, etc. We regulate our ion concentrations in extracellular fluid. It's ensuring that long-term acid-base balance is occurring. We learned a little bit of it in respiratory system. Its main reason here that we all know about it is that it's excreting metabolic waste, toxins, and drugs. So a lot of our drugs that we use in the body are either legal drugs like pharmaceuticals are used and it gets either changed or cleared by the liver or changed and cleared by the kidneys. And also we remember from blood, a lot of this will be a little bit of a review for you guys, which is great. So producing erythropoietin regulates blood pressure, and renin regulates red blood cell production. They're also kidneys also help activate vitamin D. So we know the sunlight is used to the first step, and then the vitamin D goes to the liver. And the last step is in the kidney where we actually can make it into a usable form. They also carry out gluconeogenesis, which is building new glucose from other things that are not glucose if needed. And if you think about that, that's a really important thing to know about if someone has poorly managed diabetes, if their blood sugars are off. And there's different parts of the urinary system, but kidney is just a small part of it. We also have a kidney that's, and I'll show you the next slide. Kidneys here, they're mid-level. They have each a ureter, and that's a big tube that basically brings the urine on down to the bladder. And depending on male or female, we have, well, regardless of male or female, we have a urethra, but what it looks like and where it goes through is a little bit different for each of those sexes. Remember, gender is something that you associate with, something you identify as. Sex is something that you're biologically chromosome aspect. I'm a huge advocate for that. Location external. So as far as the, get out of my screen. As far as the kidney goes, there's 3 layers of support tissue. There's a fascia that lays around the outside of the fibrous connective tissue that's on the outside of the kidney. Then there's a fat capsule that actually goes around that kidney, and it's there for a reason. If we had these kidneys just hanging around that are super easy to bruise and super easy to break, and they had no cushioning, that would be dangerous. That fatty cushion is there for a reason. It's for protection. Then we have a fibrous capsule, and that kind of helps keep everything together. So if the kidneys do get infected, which is called pyelonephritis, then we can keep that infection slightly maintained. I'm sorry, you're going to view my cat the rest of this lecture. As far as inside the kidney, we have 3 different regions. We have the renal cortex, which if we look at it under the microscope, it has a little granule appearing. It's the most superficial aspect. Cortex goes around the outside. And then we have the renal medulla, which is deep to the cortex. And these have these things called renal pyramids, also known as medullary pyramids. And those pyramids come to a papilla, which I'll show you in a few moments. And they're separated by renal columns, and there are lobes of the kidney as well. And then we have the renal pelvis, so it goes from the renal cortex to the renal medulla to the pyramids to the renal pelvis, and basically it's like a giant funnel, so it's just funneling everything on through. So it funnels from the minor calyces, which come from each of the papilla. Then we get the major calyces, which collect from all the minor calyces. They empty into the main area in the center of the renal pelvis. And then they go down to their ureters. So here, just to remember, it goes renal urine flow. So renal pyramid, minor calyx, major calyx, renal pelvis, ureter. Okay, so here's a look at what we just spoke about. This is a real life kidney. This is not a real life kidney, but out here is this cortex. In the center right here, where all these blood vessels and nerves and ureter come in, is known as the renal hilum. We have the medulla, the renal medulla, which looks very different. It almost looks like little fans coming through. Then we have the areas right here, which are the, sorry, my cat decided to get me there. We have the papillas that come right out to here. Then we have the minor calyces and the major calyces coming through to the pelvis. And then this is the renal pelvis right here, going into the ureter, and then ureter goes straight down. Okay. There's two things that we need to know about, and you might hear about in your clinical practice. One is pyelitis, where you just get infection of that renal pelvis and calyces, so mainly that transitional epithelium area. And then we have pyelonephritis, which is inflammation of the entire kidney. Most common reason is that a UTI starts down low, and if it doesn't get treated in time, it can go upstream to your kidney and cause lots of damage. This is why when someone suspects a kidney infection or a UTI, you need to get that treated right away. And what can end up happening if it's left untreated, especially the pyelonephritis, if you don't get antibiotics, you can get kidney damage and lose a kidney. As far as blood and nerve supply go, remember that the kidney cleanses the blood and adjusts its composition, so it needs a huge blood source to do that with. We have the renal arteries that actually make a major part of that cardiac output because there's so much filtering that's going on in those kidneys. Another big area is the liver. And then arterial flow, as far as where it's going from, is you don't really know this in too much depth, but just know that if I were to ask you to go from the renal vein, which is renal, you go into a segment or renal artery, it would go from renal artery to segmental artery to an interlobar artery to an arcuate artery into a cortical radiate. And basically why I'm telling you this is that it's just following from the center. Instead of going from the outside in, like from the cortex in, you're going the opposite direction. So we're looking at from the hilum, where all those vessels meet up, to the most superficial aspect, into outer parts. The big players that do all the work for us in our kidneys is called the nephron. There's what responsible for making urine. There's two main parts of and there's about over 1 million per kidney. And we've seen them a little bit when we did microscopics during week 1. So they almost look like a little ball of blood vessels, and they look like it's just been squiggled up like a giant thing of twine that has come together. There's two main parts of the nephron, and the renal corpuscle and the renal tubule. And I'm actually going to go to a picture real quick. So this is the renal corpuscle, and then we have the tubule that comes down. Okay, so I'm going to come back up. So we have two parts of the renal corpuscle that you need to know about, and one is the glomerulus. The glomerulus is a bunch of capillaries that have fenestrations, which means little holes inside the endothelium. They're very porous because this is where a lot of our filtrate formation happens. So certain things can pass through. Things that we don't want to see pass through here at this point is albumin or protein. If protein has made it to our urine in large amounts, then we know there's something wrong with the glomerulus. Same thing with a large amount of red blood cells. If a lot of red blood cells called CAS come through, then we know that's something wrong. And then the glomerulus has something called a glomerular capsule. I'm going to refer to now as Bowman's capsule because that's how everyone refers to it. So hold on one second. I'm going to pause here. We want to resume our share. Hold on. I want to pause my screen here. Okay, so we're back. I'm trying to get my cat out of my space here. So we have Bowman's capsule. Basically, it's this giant ball of twine, which is your capillary tuft, sitting in this little cup, Bowman's capsule, and it sits there and allows the filtrate to, so the glomerulus is where the capillaries are doing the filtration, and whatever we're filtering out of the blood at that point is going to go into the Bowman's capsule and down into the rest of the nephron. So we have two parts. We have two parts that make the Bowman's capsule. There's two layers. One is simple squamous epithelium, which is the parietal layer, and visceral layer. It clings to the glomerular capillaries, and it has these things called podocytes. And those podocytes are really important for this Bowman's capsule. So we have the glomerulus, which is a twine ball looking thing that has a bunch of capillaries that have lots of fenestrations or holes in it to allow for filtrate to happen. And then we have the Bowman's capsule or glomerular capsule, which is the cup. leading to the rest of the funnel and the rest of everything to get filtered on out. And in this cup, we have podocytes that kind of hang out like this, like a seesaw, and have little finger projections along the cup. And what they do is those actually help cling to the basement membrane, and they allow little processes that allow little slits to be made, so it allows filtrate to pass into the capsular space as well. When these podocytes are broken, it actually affects the net charge of the sorry, you're gonna hear my husband working in the background too. You're gonna affect the net charge of things, and when our net charge is affected, so if we start losing some of that positive or negative charges of our Bowman's capsule, guess what? It could repel certain things or attract certain things that, remember, like if you guys remember from physics, negative repels a negative, but negative loves a positive, and they come together. If we're having repelling or things that we don't want to come together, guess what? That's being pulled in to the filtrate, and we're losing it from vital things that we need from the blood. So the glomerulus has an entryway. So the glomerulus is getting it's getting fed from the capillary bed itself. The little twine ball is getting fed from the afferent arteriole. The way I remember is A becomes before E. So afferent is bringing blood into the glomerulus, and then we have something called the efferent arteriole, which is bringing blood out of the glomerulus. And these afferent arterioles come from the cortical radiate arteries, and they also help to form this little peritubular capillary system. So imagine that my hand is a nephron right now. So we have, this is why I wanted to do this a little bit live, but it's totally okay. We have our little tuft here, our capillary bed, our glomerulus, our Bowman's capsule. We have the rest of the nephron coming down here. Then imagine, sorry, yes, this is my son's play doctor jacket. So then we have a bunch of capillaries that come around and tuft around, because we need to have a constant interlocking with our blood system. Otherwise, how are we gonna fine tune what we're filtering out if there's nothing to filter out? And blood pressure in the glomerulus is always high because the afferent arterioles are larger in diameter than the efferent arterioles, and arterioles are high resistance vessels. So the high resistance are in there because they have a little bit less muscle inside, and they're keeping that blood pressure constant. And then the glomerulus itself has 3 layers, as we talked about. So we have that fenestrated endothelium, which is the glomerular capillaries. We have a basement membrane. So this is just like any kind of different type of layer system. It has a basement membrane that cements everything together. Remember those foot processes of the podocytes. Remember, they're the little guys that hang out here. They're meant to allow better filtration into that Bowman's capsule space. But so the filtration drops in, drops out, but also is really important for keeping that charge together. We then have, and I'm gonna actually, in the middle of this, yeah, stop. One second. So we're gonna go back here. So we have something called the juxtaglomerular apparatus, and this is what it looks like. So we're here in the glomerulus, and then right here next to where those efferent arterioles come, we have the juxtaglomerular apparatus. And that has a super important job, because what it's doing, and we'll get into the rest of the nephron in a little bit, but what it's doing is remember that renin that we learned about, the renin, how it regulates the blood pressure? Guess what? This is where it's coming from. Renin is made by the juxtaglomerular apparatus. And it's made of 2 different things. It's made of the macula densa, which is an area of special cells that are part of the distal convoluted tubule. And this is hanging out at the side of the glomerulus right there. So it's not, I'll show you in the next slide here. So the macula densa is actually sensing the salt concentration in the tubule. And when it senses that salt, remember, water follows salt, or water follows salt. So what happens is that if it senses a change in the sodium concentration in the tubule, it'll actually change the blood pressure itself. And then the juxtaglomerular cells of the afferent arteriole are responsible for making that renin. And these cells are made from smooth muscles, and that's why they have so much more oomph to them. So this is taking a look here. We're juxtaglomerular here. We have macula densa here. Okay, so remember, juxtaglomerular apparatus makes the renin. I'm waiting for you guys to interact and you're not here, but that's okay. I'm going to play it around. And macula densa, remember, that's sensing the sodium chloride concentration. Okay. And remember, the vasorecta helps make urine. It's a little loop that goes, remember that little thing where I showed you with my son's doctor jacket? Yes, I have a doctor jacket for my kid because I'm a dork. It's going around these little areas, and it's helping with more urine formation. So if we looked at the renal cortex under the microscope, what we would see is we'd see this glomerulus right here, and see all these rich red blood cells. Look, see how it looks so different. And then different areas here, out here are actually all the different tubules here. So you can actually see right here that this is the distal convoluted tubule right here. Sorry, that's the proximal convoluted tubule. And this is the distal convoluted tubule right here. So now we're done with the glomerulus. We talked about the glomerulus. We know that's we're doing all the main filter of the solutes from the blood. Now we got to concentrate, refine our urine so we're not losing stuff that we need and we're not holding on to stuff that is toxic. So the first part up here, so remember, this is not exactly, I'm pointing here like you can see, sorry. This is not exactly how it looks in real life. This is just a schematic. It's all kind of all intertwined with each other. But the first part here is called the proximal convoluted tubule. And it's convoluted, meaning it's, you can take a look and see how it squiggles everywhere. Its main job is to reabsorb ions, water, and nutrients, and helps remove toxins and adjust the filtrate pH, which is going to be important. Then we're coming down here. So proximal convoluted tubule is going behind here with a descending loop of Henle. It has these special pores called aquaporins and allows water to pass from the filtrate into the interstitial fluid. Then we come here and then we don't really go in too much depth about the loop here, but we have the ascending loop of Henle right here. And we reabsorb sodium and chloride from the filtrate into the interstitial fluid. Brings us up to the distal tubule right here. And this will secrete different and absorb different ions depending on what we need the body to do. It's fine tuning section. It helps maintain blood pH and electrolyte balance. And this goes down to the collecting tubule, collecting duct. It helps reabsorb solutes and water. It makes the last little minutes until you pee it on out. Okay, so things that we need to understand, there's three different terms here that you need to know. So glomerular filtration produces cell and protein-free filtrate. So it is literally just the pure everything but the cells and the protein, which is why we don't want to find white blood cells in our urine. We don't want to find protein in our urine. They're not supposed to be there. Tubular reabsorption. So this is selective and it returns 99% of the substance of the filtrate to the blood in the renal tubules, from the filtrate to the blood in renal tubules and collecting ducts. And they have tubular secretion. So reabsorption means it brings it back in. Tubular secretion means it puts it back out. So this is moving substance from the blood to the filtrate in the renal tubules and collecting. So tubular absorption is bringing it back into the blood. Tubular secretion is bringing it back into the urine. Okay. I love this diagram. It does a really great job of helping out. So remember, filtration's all here. Nephron, they have this is a great thing to look at here. So in the proximal convoluted tubule, we do the majority of our water absorption here. Permeability of water is very high over here. This is vital. If something happens to our proximal convoluted tubule, we can't do the rest. I don't want you guys to worry all about the different things here. I want you to understand that reabsorption secretion of the proximal convoluted tubule is really important. And this is where the majority of the water is happening here. We then, in the loop of Henle, this is where our solute concentration comes in. So our sodium, our potassium, those type of things, mainly sodium. And there's absolutely no water absorption, the descending or ascending loops here, okay? At the loop of Henle, for your purposes here, I don't want you to associate any kind of water association with it. And then in the distal convoluted tubule and the collecting duct, we have some reabsorption, but this is where some optional secretion is occurring, and the water permeability is variable. So remember, this is where the majority of it happens. This is fine tuning along the way if we need it. And we looked a lot in a few of these chapters about systemic blood pressure. I'm not going to go into much depth on this, but we now know the renin-angiotensin aldosterone system and how it works. So if we're looking at if the drop in blood pressure comes here, we're going to have a drop in what's called a glomerular filtration rate, because without that high pressure system, guess what? The GFR doesn't do a great job, or that filtration doesn't do a great job with that pressure pushing it through. And then what happens is that filtrate flow decreases, the sodium concentration decreases the ascending limb of the nephron loop. And guess what? Our macula densa senses this change here, that sodium, that salt concentration, and it tells the jugular apparatus to get to work and makes renin. Okay, so then renin's going to come in, and it's going to do, it's going to cause some vasodilation over here. And sorry, you can go here. So you see some vasodilation of the afferent arterioles, and in turn, that's going to increase GFR. If we increase GFR, guess what? That's going to increase, what are we going to do? So we're going to increase our ability to filtrate and maintain that blood pressure properly. So as far as physiology of the kidney, about 180 liters of fluid is processed daily, but only 1.5 liters of urine is formed. So we do a ton of work with our kidneys. That's where they're so important. They filter the entire body's plasma volume 60 times a day. They're busy. When we do things that don't make our kidneys feel good, like not drink water or drink a lot of alcohol or a lot of coffee, it doesn't do us very well. They also take about 20 to 25% of oxygen when our body's at rest. And urine is the main product that we're getting out of this. So urine is about less than 1% of the original filtrate. And what we're doing is we're getting out all the stuff that our body does not need, or the things that our body is toxic if we keep it inside. And then what else can affect this GFR, this glomerular filtration rate? So there's certain drugs that can affect it. There's certain chemicals that can affect it, such as adenosine or prostaglandin E. And remember that we have angiotensin 2, which is helps regulate the blood pressure as well. So as far as intrinsic, how our kidney self-regulates, we have a few things here. And then we have extrinsic. I don't want you guys to worry too much about it. Just understand, I really want you guys to concentrate on the extrinsic controls of GFR, which is helps maintain our blood pressure, helps hormone that RAA system. Baroreceptor reflex is important, and the mean arterial blood pressure is what regulates the GFR. You might see this term come up in clinical practice called anuria, which means that you don't pee a lot or there's not a lot of urine coming out, about less than 50 mils a day, which is enough to fill up like maybe a teaspoon or tablespoon. This can indicate that either glomerular blood pressure is too low or renal failure is occurring. And why would we have anuria? Sometimes it's from crush injuries. Sometimes it's because there's a kidney stone blocking it. Sometimes, remember, itis is an inflammation. So there's inflammation or infection. And sometimes one of the biggest problems when we do blood transfusions, remember, lots of the blood gets filtered into the kidney and a lot of it gets backed up over there, and it can cause renal failure because it doesn't recognize self. Things start clumping together, and before you know, it's not a good party. Okay, so again, here's this slide here for you guys to review. It's super helpful, super useful. I want you to remember the main things up here for now, okay? As far as tubular reabsorption, so we're talking about the majority of how our sodium gets across these membranes. It's done by secondary transport, active transport, which means it needs a gradient to get reabsorbed. There is some pass-through reabsorption of the water here in the proximal convoluted tubule. I'm not going to have you guys really responsible for much of this. But aquaporins, remember, they're always available in the proximal convoluted tubule because those are the things that regulate the water permeability. And in the collecting ducts, what really represents if we're going to reabsorb water or not is antidiuretic hormone. So remember, that's our fine tuning. Our antidiuretic hormones are anti-piss hormone. So if we need to hold on to some of those things and keep it so the blood can filter a little bit more, then we're going to do it. And then I'm going to skip over these because they're not super important. As far as the proximal convoluted tubule, what I want you to know is most of reabsorption happens here. All nutrients, glucose, amino acids are reabsorbed. About 65% of our sodium and water are reabsorbed here. And about half our urea is reabsorbed here. But remember, we don't want to hold on to urea. Urea is toxic if we hold it on. So it actually ends up getting secreted back into the filtrate at a later aspect. Then we have the loop of Henle or nephron loop. So the descending limb, water can leave, but cellulose can't. Ascending limb, HDO cannot, water cannot leave and cellulose can for the most part. I want you to remember as the loop, as for simplification purposes, is that no water. We're just not going to think about water when it goes there, okay? And the distal convoluted tubule and collecting duct, remember, this is our fine tuning. This is secretion that's going to happen. This is some reabsorption. So we have antidiuretic hormone that works directly. So remember when we learned about hormones, we have antidiuretic hormones coming from the posterior pituitary. These concerned cells of the collecting ducts to insert these aquaporin, these little pores that actually change the water permeability of that convoluted tubule and that collecting duct. And when we increase ADH levels, it causes more water reabsorption because it's anti-piss. So if we don't pee it out, we're going to reabsorb it back into our blood. So that is, make sure we don't confuse that. The difference with that with aldosterone is that aldosterones are, it works on the collecting ducts and the distal convoluted tubule too. What it does is it filters, it helps maintain blood pressure and potassium levels. And we do this because it's responsible for helping out the sodium potassium channels being made and the sodium potassium pumps to be made as well. And remember, without aldosterone, if you had no aldosterone, you would lose about 2% of your sodium. Remember, where sodium goes, water follows. That's incompatible with life. We have a couple hormones that are made from the renal tubules and the collecting ducts. First hormone is atrial natriuretic peptide, and this helps reduce blood sodium, which you remember, sodium follows water. So if we reduce the blood, we're reducing the blood volume, reducing the blood pressure. And it's released by cardiac atrial cells. So in the atria, we didn't go into too much depth because it's a little too advanced for you guys, but it's a fun fact. And the parathyroid hormone works directly on the distal convoluted tubule and it helps increase calcium reabsorption. So it brings our calcium levels back up. So here's another really great summary of what's getting reabsorbed, what's not. For the purposes of our lecture, I want you to remember the loop of Henle as no water, because it gets a little too confusing when we're going into other aspects. So tubular secretion is reabsorption reverse, which means that most of it's occurring in the proximal convoluted tubule. So we don't need it. We want to pee it out. So guess what? We're going to excrete it back into that tube. And things that can go in and out of these tubes are potassium, hydrogen ions. Remember, it helps their acid-base levels. Organic acids, bases, stuff that we've actually consumed. Creatinine, which is a byproduct of muscle. And then NH4 is ammonia. So ammonia is super important. It helps form urea, and it's important for our balance here. So tubular secretion is important because so there's certain drugs that are bound to plasma proteins. If we need to get rid of them, then we need to get rid of the plasma protein that's associated with. Things that we don't want in there, like urea and uric acid, is really important because that's where tubular secretion comes out. Aldosterone, remember, it's trying to get rid of the extra potassium as a blood pressure effect. So it helps get rid of it. And then controlling the blood pH, it actually can sense hydrogen or bicarbonate in the urine. And then what's important to know is that the juxtamedullary nephrons, they create this osmotic gradient with the renal medulla that helps, basically this gradient helps produce the urine concentrations. I didn't go into too much depth like I did last year because it's way too much information you guys don't need to know. And then how do we make our urine dilute or concentrated? Now this osmotic gradient is responsible for that, because if we have an osmotic gradient established, then we can actually change our osmolarity of our urine. Osmolarity is the amount of solute that's in our urine or in our blood. Overhydration produces a large volume of dilute urine, so there is such a thing as drinking too much water. I know I tell people to drink water all the time because most of us don't drink enough. But if we overdrink, what we end up having is that we get too dilute of urine, which causes electrolyte imbalances, the whole 9 yards. So we don't want that. Remember, antidiuretic hormone, anti-piss. So if we have too much water that's going, if we have too much hydration, too much dilute urine, then the antidiuretic hormone actually production decreases, because we want to try to get some of that out. And then dehydration is a little bit opposite. So dehydration makes a small volume of concentrated urine. And severe dehydration. So if you're walking in the desert for 40 days, 40 nights, then 99% water was reabsorbed, and that's not good. Urea is a waste product from our muscle work and a lot of our protein metabolism. And we need this urea to help form that medullary gradient because it allows our, basically in a nutshell, this medullary gradient is really important to making the osmolality and the concentration of urine. You guys will be doing this in lab. You're going to be doing urine analysis. So this helps examine for signs of disease. We could also test for many illegal substances. You can test about just any drug in the urine. It's assessing renal function. But at the same time, there's certain things that we can't determine by just looking at the urine, which is how well your urines are filtrating at the rate that they're going and the amount of creatinine that we actually see in the blood. And then sometimes we need to look at the nitrogenous waste. So we need to look at that urea. We need to look at some of our clearance rates there. And creatinine is a way for, and BUN, blood urea nitrogen, is a way for us to get rid of those nitrogen balances here. So if I ran a UA on someone, what I'm going to look at are these things here. We're going to look at a BUN. Actually, this is not urine. This is a blood test. Okay, sorry about that. So things that we look at the blood, we're going to look at the BUN, which is blood urea nitrogen. And that's going to tell us about our urea nitrogen content. We're going to look at glucose. We're going to look at creatinine because it's a byproduct of metabolic waste. We're going to look at our EGFR. So a fun fact is that African American population has a different estimated GFR than the rest of the population. I think it's just genetics there. And sodium, potassium as well. So we can have chronic renal disease. And the biggest things here of chronic renal disease are diabetes, actually. Diabetes is one of the biggest, diabetes and high blood pressure are the biggest reasons for chronic renal disease. These are two things that we can do a lot to prevent in our society. And chronic renal disease is when that GFR, that glomerular filtration rate, is less than 60 for at least 3 months. And what does that happen? So if our kidneys, our glomeruli are not filtrating really well because the higher blood pressure has affected the ability for things to happen. Diabetes mellitus has destroyed some of the vessels. So that filtrate formation decreases, nitrogenous waste accumulate in the blood, pH becomes more acidic, and it becomes deadly. And renal failure is when the GFR is less than 15. This is super deadly. And this is where you need dialysis or a transplant on board. Okay, so as far as urine, you're in, you're out. Haha, had to say it, sorry. So as far as chemical composition goes, 95% of our urine is water, 5% is solutes. We get all of our nitrogenous waste out from our urine. That's urea, which is amino acid breakdown. Creatinine, which is creatine phosphate muscle breakdown, uric acid, which is from nucleic acid breakdown. We'll find a little bit of sodium, potassium, phosphate, sulfate, calcium, magnesium bicarbonate, and abnormally high concentrations. Any of these can indicate a pathology. So UA is what we're looking at, urinary, what you guys will look at lab. You're going to look at some physical characteristics. You're going to look at the color and transparency, because cloudy urine normally means that there's an infection or possibly a dehydration status, as well as pale to deep yellow. Sometimes if the color is not as is a little bit deeper, then we know that it's basically means a little bit of your hydration status. And sometimes if we have some hemoglobin broken down, it could change the color. Any abnormal colors like pink, brown, smoky. Certain foods can change your urine. Things like B vitamins. If anyone took a B vitamin complex, you might notice that urine is like bright orange. Lots of asparagus can change it. Bile pigments, blood, and drugs can change it. We also look at the odor, which I know is gross, but when urine's fresh, it should be slightly aromatic. And yes, I do have to whiff urine frequently. If it sits over time, ammonia odor can kind of form. Or if you ever hang out and like, if you went to a rest stop and you smell it smells like ammonia, that's because there's probably not a clean restroom. And if ammonia odor is there, that means that bacteria are probably there as well. Certain drugs and vegetables. I always put asparagus. Asparagus can change the way that you pee and the way it smells. And certain diseases. People with diabetes, they might have a slight acetone smell to their urine. The pH is something we look at. So urine is always slightly acidic at about a 6, but a range is 4.5 to 8. Acidic diets are from high protein, whole wheat can drop the pH. Alkaline diets, vegetarian, prolonged vomiting, urinary tract infections can all increase pH. I'm not going to get into the whole mumbo jumbo about alkaline diets versus acidic diets. Everyone's different. Everyone's got a different body. Ask your doctor. Specific gravity is basically looking at the definition of specific gravity is the ratio of mass of substance to mass of equal volume of water. Specific gravity of water is always 1. We're trying to see if how much solute is in there, basically. So the normal range is 1.001 to 1.035. So we talked about our kidneys, we talked about some of the major aspects of it. Now we're going to figure out how to get this urine out. So we came down the renal pelvis, we're into the ureter. Each kidney should have 1 ureter, but guess what? Some people are born with 2, some people are born with none, some people are born with splitting ureters. It happens. Okay, and the ureters tend to begin at the level of L2. So a lot of times when people have kidney stones that are really large, they might say they feel some back pain around L2. The ureters are also retroperitoneal, and where they enter is at the posterior wall of the bladder. And as the bladder pressure increases, which means more urine is there, the distal ends of the ureter close, preventing backflow of urine. So we shouldn't have backflow of urine going from the bladder back up the ureters into the kidney, because that would be bad. The ureters are a tubular structure, just like we were looking at any other tubular structure. So they have layers. There's 3 layers I want you guys to know about. Mucosa, which is transitional epithelium. And to move back a few slides, so anything that has collecting urine. So the major calyces, the minor calyces, the renal pelvis, they're all lined by transitional epithelium, okay? So the mucosa is transitional epithelium of the ureters as well as the bladder and urethra. We have a muscularis, which is smooth muscle. And in the ureter, what they do is they help propel urine into the bladder. So they push it with peristalsis, just like we would with pooping. The rate of the peristalsis is just adjusted for how much urine we're making. And remember, sympathetic and parasympathetic nerves innervate the ureters, but they don't make a big role in peristalsis. And then we have adventitia, which is the outside layer. Now we have something called renal calculi. These are absolutely horrid. I've had quite a few in my life. They suck. So a lot of times they form in the renal pelvis, and what they are made of normally calcium, magnesium, or urea or uric acid. Large stones can actually block the ureter, obstruct the urine flow, cause excruciating pain from flank to abdomen. We have nephrolithiasis, which is when calculi are in the kidneys, and this is the most painful part, which is ureterolithiasis, when the calculi are lodged in the ureters. So fun fact, they expect that you should be able to pee out any kind of kidney stone or renal calculi that's under 5 millimeters. Over 5 millimeters, you normally need surgery. The lumen of the ureter is about 1 millimeter diameter. So anything bigger than 1 to 2 millimeters normally hurts. As far as the bladder is our sac. It's our temporary storage of urine. It's kind of like the gallbladder, where the gallbladder stores the bile. It's retroperitoneal, and it's on the pelvic floor posterior to that pubic symphysis, which is the area where the cartilage meets the 2 parts of the hip bone. In the males, the prostate is inferior to the bladder neck, which means the prostate sits right below the bladder neck. And in females, the vagina and uterus are anterior to the bladder. So a lot of times when women are pregnant, they feel like they have to pee all the time because their uterus is getting bigger and it pushes on their bladder. As far as openings, where are these ureters going into? They're going to a place called the trigone, and they're on the posterior aspect of the bladder. And that posterior aspect of the bladder then also allows an area for the urethra. And the urethra is the exit route where we pee, okay? So it's a little smooth triangle area where all the things come together. And if someone gets an infection, it tends to persist over here. So it's really important when we think about bladder infections that we want to get them quickly. Not get them quickly, but treat them quickly. As far as layers of the bladder wall, remember it is a sac as well. We have the mucosa, which is transitional epithelium. There's a very important muscle here that we don't have any control over. It's called the detrusor muscle. It's kind of like the muscles that we find in the GI tract. And its job there is to allow squish, 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 get that urine out. And then we have an adventitia. So this part right here, this is not the male. Well, we don't know. They're trying to do a gender, sexless here. But we have here the dome of the bladder up here. This is the posterior aspect with a trigone. We have a lot of these rugae because remember that the rugae allow the urinary bladder to expand. So there's more mucosal surface and contract. So when there's a lot of urine in here, guess what? It's really big. When there's no urine here, it's very tiny. It's like a balloon. We have the ureters that come here at the ureteral orifices, and then the trigone empties into urethra, and we pee it out. And this, they are saying that this is female. So when urine storage capacity, so as I said, when it's empty, it collapses, the rugae up here. And then when it's full, it can get to about 5, when the bladder is about moderately full, it gets about 5 inches long, can hold up to about 1 pint or 500 mLs of urine. It can hold twice the amount if necessary, but can burst over descenders. So if you keep holding urine, you can burst your bladder. Okay, and then the exit route for everyone is the urethra, regardless if you're male or female. So it's a muscular tube that drains the urinary bladder. It's made of mostly pseudostratified columnar epithelium, except for near the bladder where it's transitional epithelium. And when we get out towards the exit route, it's more stratified squamous epithelium. Because that's a high traction area. We need that traction area to be thick. As far as how do we control how we pee, how we urinate, a fun term for urination is also micturition. You might hear that a few times. So we have just like in the GI tract, we have the internal urethral sphincter, which is involuntary. It is parasympathetic and sympathetic. We have external urethral sphincter, which is voluntary. It's skeletal muscle. It surrounds urethra, passes through the pelvic floor. The female urethra is only about 3 to 4 cm in length, and it's tightly bound to the anterior vaginal wall. And in the males, it's a lot bigger or longer. As far as the urethra in the male, we have 3 different regions because the male's urethra shares 2 jobs. One job is to bring urine out, but other job is to bring semen out. So we have different areas. There's the urethra that goes through the prostate, which is our first stop after coming out of the bladder, which is the prostatic urethra. We have then an area that's called the intermediate part of the urethra, where it's going from right where the prostate ends and the beginning of the penis starts. Then we have the spongy urethra, which passes through the penis and opens to external urethral orifice. So this is taking a look here. We have our prostatic urethra, our membranous urethra, and spongy urethra going through here. As far as urinary tract infections, I can't say this enough. These are not something that you want to get and ignore and hope it goes away, because they will not go away on their own. Normally it's from wiping improperly. That basically what happens is that most urinary tract infections are from E. coli. E. coli is not naturally found in the urinary tract. It's found naturally in the GI tract. That's normally because when people are wiping, they're wiping the wrong direction. And this mainly is really for females, for the most part, the biological females, or actually, no, I take it back. Female gender, because if you had a transition, then it can happen to them as well. So, so that short female, biological female, and if they have a gender confirming surgery, then they will have a shorter urethral tract, and this allows that fecal bacteria to enter. Most UTIs occur in sexually active women, and you could take a wild guess about why that's occurring. There's a lot of movement, a lot of friction, and then it's basically pushing that that bacteria into the urethra. So that's why you might hear that urinating after sexual intercourse is something to be done. There's a few different types of itises that we need to go through. We have urethritis, which is just the inflammation of the urethra. You might hear cystitis and lower urinary tract, or all these interchangeable with cystitis, urethritis, and urinary tract infection. Cystitis is the actual inflammation of the bladder itself. A lot of times we can't tell. We just call it urinary tract infection. Pyelitis or pyelonephritis is of medical importance as well, inflammation of the kidneys. Some signs and symptoms of urinary tract infection is that it gets really painful to urinate. You might feel like you have to pee very often, but very little bit comes out, or like you can't hold your pee. When it comes to kidney infection, what really determines the difference at that point, as far as me being a doctor, is that a fever and back pain will occur, because the back pain occurs because that's where the kidneys are. And most antibiotics will cure most urinary tract infections. And if you're allergic to one, guess what? We'll find one you're not allergic to. And as I said, micturition is urination, aka peeing. Micturition is not something that we really control. All we can control is that external urethral sphincter by the somatic nervous system to help us pee when we want to pee. But if we hold it too long, guess what? You have no choice there. So the contraction of the detrusor muscle is the autonomic nervous system. The internal urethral sphincter is also the autonomic nervous system. And as I said, there's a time where you might, if you hold on to your urine too long, it might cause issues. We have something called urinary incontinence, and that's basically what happens is that the pelvic muscles get weakened. We have something called stress incontinence, which is where someone last cost sneezes and they accidentally let some urine. This is from increased intra-abdominal pressure when this happens, so it forces the urine through the external sphincter without us controlling it. And then we have overflow incontinence, which urine dribbles when the bladder overfills, and that's more common in men than women. Urinary retention is also a very bad thing to have. The bladder is unable to expel the urine. Sometimes you might have this after getting anesthesia because it kind of knocks everything out. Also happens when the prostate of men and this can only happen to biological men because they only the ones who have prostates. Prostate can get really big and push on that prostatic urethra, not allowing the urine to leave the bladder. And typically how we treat this is called catheterization. We take a rubber tubing, stick it through the urethra, and allow that area to pass. That's it for this part of the lecture. I'm going to take a pause, take a drink of water, as we're talking about kidneys, and we'll talk about electrolyte balances in a moment. Okay, we're back. I'm going to share my screen, and then we're on to Funky Town. All right. So we're going to talk about fluid, electrolyte, and acid-base balances. And yes, there's a cat in my screen, and my computer's full of cat hair. All righty. So body fluid, we have body work content. Infants are about 73% or more of water. They have low body fat. They have low bone mass. Males are about 60%. Adult females about 50%. Because females tend to have a higher fat content and less skeletal muscle mass, as they say. And adipose tissue has no water because water repels fat. And then water content declines at about 45% as we get older. There's two fluid compartments that we talk about when we talk about acid-base and fluid electrolyte balance. We have intracellular fluid, which is the fluid that's inside the cells, which is about 2/3 of your body fluid. And then we have extracellular content, which is the area outside of the cells. That's about 1/3. Plasma is an example of extracellular fluid. It's about 3 liters. Interstitial fluid, which is the spaces between the cells, which is about 12 liters. So that makes a big part of it. Also considered part of the interstitial fluid are the aqueous and vitreous tumors of the eye, synovial fluid of the gastrointestinal tract, serous fluid, lymph, and cerebrospinal fluid. So here's just a breakdown there. Water is a universal solvent, so that basically anything can dissolve in water. Solutes are substances that dissolve in water. We have solutes that are classified as non-electrolytes and electrolytes. Non-electrolytes are mostly organic molecules, and they do not dissociate in water. These are glucose, lipids, creatinine, and urea. And I don't know why I always think of idiocracy when I think of this one, but electrolytes, what plants crave? Electrolytes are our sodium, potassium, etc., chloride, etc. So electrolytes dissociate into ions in water. So we take table salt, it's going to dissociate into sodium and chloride. Magnesium chloride is going to dissociate to magnesium and 2 chlorides, and glucose does not electrolyte. So it's just glucose, doesn't dissolve into water. And then ions, remember they have a positive and negative charge, so they have electrical current that are composed of them. So extracellular fluid, remember when we're learning about the nervous system, we should all know this pretty well. Outside the cells, a lot of sodium. Inside the cells, a lot of potassium. And when we switch those things around, we get that lovely action potential. And then as far as inside that's the only things that really, you can know about the major anion, which is chloride, being inside the cell, and the major anion being, outside the cell, and major anion is phosphate, but it's not really important there. Comparison of intracellular and extracellular fluids. So remember, electrolytes are most abundant solids in the body fluids. They determine most of the chemical and physical reactions in our bodies. So we need these things to do things in our body. Bulk of the dissolved solids are in our proteins, phospholipids, cholesterol, and triglyceride. Remember, 90% of this is in our plasma, 97% is in our intracellular fluid. Fluid movement all depends about osmolality, and osmolality is how much solute concentration is in there. So osmotic and hydrostatic pressure, so osmotic pressure is made by is also known as colloid pressure, and that's due to albumin. Hydrostatic pressure is how much pressure the actual water exudes. So remember, water moves freely among osmotic gradients, and all body fluid osmolar is almost always equal. So if we change the solute of any compartment, leads to net water flow. So if we increase the extracellular osmolarity, water will leave the cell. If we decrease the extracellular osmolarity, water will enter cell. And remember, in the beginning of the course, when we learned about blood cells, hypertonic, isotonic, hypotonic, that's the same theory here. As far as exchanges between plasma and interstitial fluid, they occur through capillary walls. And the lymphatics pick up the remainder of what doesn't get reabsorbed. That's the whole purpose of them. Exchanges between interstitial fluid and intracellular fluid occur across cell membranes as well. There's two-way osmotic flow of water. Ions, remember, help these move selectively into or out of the cell. And then nutrients, waste, and gas have a unidirectional flow. So if we're taking a look here, we're looking at the level of blood plasma, interstitial fluid, and cellular. Oxygen, freely moving. CO2, we don't want that in our cells, comes out, etc. Water balance and osmolarity. So we must take in enough water to equal the water that we put out, and that's about 2,500 milliliters in total per day. Water intake, the majority of our water intake is through beverages. And when I say beverages, I really prefer to take water in. When there's something like soda or sugar or caffeine or salty or whatever, it actually takes away the amount that your body can. I actually had a couple of patients and a couple of students go, well, I drink so much tea. That's not so bad. I'm like, well, tea has caffeine, and caffeine dehydrates you. Fun fact. We also have a small amount of ingested foods, but remember, the type of food that we eat depends on the amount of water. Banana has much less water than an apple or an orange. And then metabolic water, which is water of oxidation. This is water that's produced from cellular metabolism. So when we're talking about the oxidation phosphorylation chain, we're talking about this. And then water output, about 60% of it is urine. And then we have insensible water loss that it happens through our skin or lungs through perspiration and feces. We have a happy space of our osmolality of our extracellular fluid. Osmolarity, if we have a happy space of where it wanted to be, 280 to 300 millimoles osmolarity. An rise in osmolarity normally tells you that, remember, that the solute is too high, so we get some thirst sensor in our brain to go off, and antidiuretic hormone can get released. Opposite occurs if you have a decrease in osmolarity. So how much solute is in our water, in our body content, and actually dictates how thirsty we are. Oh, Dr. Wood, I'm never thirsty. That happens. We have certain people that just don't ever have a thirst drive, and that's something to ask your personal doctor about. Sorry, that happens every class. So as far as regulating water, remember that thirst mechanism is a driving force. We don't have to learn to be thirsty. We are born with that innate feeling to be thirsty. It's governed by the hypothalamus, and it has osmoreceptors that detect the extracellular fluid osmolarity. And certain things that activate it are if the blood plasma osmolarity is increased by 1 to 2%, guess what? That thirst center gets turned on. Dry mouth, the body thinks that we need to drink water. Decreased blood volume or pressure, guess what? The body's going to think we need to take in more water. Angiotensin 2 or baroreceptor input, guess what? If that goes off, then that's going off because it's sensing a decrease in blood volume. It's going to be, or a decrease in blood pressure. We need to rise that blood pressure. We're going to drink water. When we drink the water, it inhibits the thirst center. So it's like when we eat food, we are not hungry anymore. It's an inhibitory feedback signal. And it basically, if we don't have dry mouth anymore, we probably don't want to drink anymore. And it does, stomach and intestinal stretch receptors can also have a feedback loop on here. So there was an old school, I guess, trick or something that people, I mean, it's not a trick, it works. But drinking a full glass of water before meals, normally a way to get those stretch receptors too, so you don't overeat, but always ask your doctor before making any dietary changes. And here's just a little bit in detail. This woman's really thirsty. She went for this amazing run in the middle of Hawaii because the pandemic's over and she can travel. Yes, I'm a little upset. I just canceled my trip to Maui because it's not going to happen. All right, moving along. Wah, wah, wah. So obligatory water loss is things that we cannot live without that happen. So that's why we always need water. We can only survive about less than a day without water. We can survive almost a week without food. So when our lungs or skin, that just happens. That's insensible water loss. Sensible water loss is from urine and is from sweat and from feces as well. And it helps. So if we sweat a lot, then guess what? We need to drink more water. So how does antidiuretic hormone react to this? We already went over this quite a few times. Remember, antidiuretic works directly on water reabsorption in the collecting ducts. And then a decrease in antidiuretic hormone means that you make dilute urine, and I have a drop in body because you're antidiuretic. So you're not trying to stop the piss, you're having the piss happen. So it's not bringing a ton of water back in. So other factors that trigger ADH, sometimes decreases in blood pressure can trigger ADH, like we discussed. And sometimes decreased blood pressure or volume can be caused by intense sweating. So some people feel like that intense sweating, vomiting, diarrhea, severe blood loss, traumatic burns, or prolonged fever. So the most dangerous part of having a 3rd-degree burn is actually the dehydration, because you lose so much water and so much blood volume with that. We've already went over this in great depth. I'm not going to go into much more there. Antidiuretic hormone, water reabsorption. Okay. Disorders of water balance, that's dehydration. Sometimes when people are dehydrated, it's because there's extracellular water loss. So severe burns, like I said, hemorrhage, lots of vomiting or diarrhea, you don't get to drink water, you're abusing certain things, or there's something wrong with your endocrine system. Sometimes there's conditions like the Addison's or Conn syndrome from the adrenal gland that can affect things. Typically, we know we're dehydrated. One, it's not listed on here, but it's continency oral mucosa. You get thirsty, you get dry flush skin, you don't have a lot of urine. A lot of people get like this brain fog, not mental confusion, because that's when it's severe, but they get like a brain fog, or they feel really hungry because they're just trying to fill something, they're not sure what it is. And then what ends up happening if we get really dehydrated, we can have weight loss, shock, loss of electrolytes, basically death. Okay, so we have excess. So if we're going for a run in the middle of the desert and we're not feeding our body's water to keep it hydrated, we're getting this loss of extracellular fluid. The extracellular fluid, osmotic pressure rises, and guess what? These cells start to shrink. Shrunken cells is not a good thing. Hypotonic solution is when the cellular cells are overhydrated, or water intoxication that I was talking about there, that it's dangerous to drink too much water. Yes, we drink water. Too much is a bad thing. It's hard to get there, but do not test that water. No pun intended. So what happens is that the extracellular fluid osmolarity decreases, and we have hyponatremia, and this is dangerous because we don't have enough salt in our blood. We don't have enough salt in our blood. You can only imagine what's going to happen everywhere else in the body. So basically death. We treat this with hypertonic saline. So here's what happens when we overhydrate. This woman is just going to town here on water. She looks like she knows she's doing something bad. And then cells swell and they can burst. Edema is another disorder of water balance, where is typically there's too much interstitial fluid that accumulates, and it's tissue swelling, not the cells, just the tissue is swelling. We'll see this sometimes with certain like cardiac diseases. And the electrolyte balance, I always want to say it, sorry, it's what plants crave. It's electrobalance, it's what plants crave and what we crave too. Usually it refers to only salt for the most part, but we do have other electrolytes that we're really concerned about. Remember, salt controls fluid movement. It provides minerals for excitability. We know all the things that salt does in our body right now. We haven't got to anything at all that's coming up in later lectures that we haven't already discussed about the importance of salt. But too much salt is a bad thing, could raise your blood pressure too. So we get it either by metabolism or ingestion, and then we lose it by pooping, peeing, vomiting, or perspiration. preferably not through vomiting. Okay. And here are some of the issues that what we do and what happens with different electrolyte imbalances. I will let you guys read that at your leisurely. These are all dangerous. Hypercalcemia, that's not good. That can cause cardiac arrhythmias. Hypocalcemia, that can cause tetany. We have hyponatremia, we already know about. I'm going through the ones that we don't know. Hyperkalemia can cause flaccid paralysis, which means your muscles have no rhythm whatsoever. Hypokalemia is also bad because it can cause cardiac arrhythmias. And then when we have severe electrolyte deficiencies, we might have cravings. So when you guys did your food journal, and once again, hashtag not giving you guys medical advice, teaching you about your body so you can be better students, you might notice that you have cravings certain times of the day or certain things. And that's normally a sign that there's electrolyte that's deficient. So a lot of times, if electrolytes are low, you might, like if you had a lot of pickled eggs or if you want a lot of pickled eggs or smoked meats, that's something that's a salty or sour food craving. I don't know who would want to crave pickled eggs, but if you're on that boat, great. And then Addison's disease, remember we have to add the hormones back because the aldosterone is not being produced by adrenal cortex. Aldosterone, that is salt we need. And then there's a disorder called pica or pica. And basically people just have this need when it's a really bad electrolyte imbalance. They are trying so hard to get this mineral or get this electrolyte back into them. So they'll eat chalk, clay, starch, burnt match tips. I've actually seen a few patients with these things. And normally there's deficiencies in iron a lot of times, but there's also deficiency in electrolytes. And remember, sodium is the most abundant cation in the extracellular fluid. Not going to go into all this. We know all about this stuff. But we do know, what we don't know is that renal acid-base control mechanisms are coupled to sodium ion transport. So when we need to keep our blood pH correct, it's really important to have that sodium balance correct. And here's some of the homeostatic importance. So we need that extracellular fluid. You guys can read this. The sensors are osmoreceptors for osmolarity. Baroreceptors are for volume and pressure. How do we affect the extracellular sodium concentration? We have ADH and thirst mechanisms. Body sodium concentration, we have ANP in the RAA system. There are no known receptors that monitor NA levels directly in the fluid. We can actually in the body fluids. So just remember that. But we can sense their concentration. And I'm not going to go into too much depth here, but aldosterone and angiotensin 2. We know that aldosterone is responsible for making 65% of the sodium being reabsorbed in proximal tubules. Okay, we already went through all this, which is why I'm not going to re-lecture about it again. It's a lot of, we were talking about Addison's, the importance there. We need to add that aldosterone in. Atrial nitropeptide, it's released by the atrial cells in response to stretch caused by increased blood pressure. So what does it do? It helps decrease the blood pressure and blood volume. And then we've already gone to this pointing here, this into complete detail. I'm not going to go into any more. As far as what regulates other hormones of the sodium balance, so believe it or not, estrogen and progesterone play a huge role. There's actually a reason why women will feel bloated around the periods. So estrogens tend to increase sodium salt reabsorption like aldosterone. So bloating can occur during menstrual cycles and pregnancy. And then progesterone actually decreases the sodium reabsorption and can promote sodium and water loss. So with that being said, when we'll go into that, actually we'll go into that next week. Don't worry about it. The glucocorticoids, they have increased sodium resorption and promote edema. We have some cardiovascular baroreceptors. We know about the baroreceptors. They're here in the carotid sinuses. They alter the brain. Oh, sorry, they don't alter. They alert the brain to increase the blood volume, blood pressure when needed. So sympathetic nervous system impulses to the kidneys decline. We get the afferent arterioles that dilate. Remember, the afferent arterioles are what controls the blood pressure, not so much the efferent. We're more concerned about the afferent. GFR increases, doing more output, and then we reduce blood volume and pressure. We already went into this crazy. Potassium, we know that affects resting membrane potential in nerves and muscle cells, super important. It's also part of the body's buffer system. Hydrogen ions can shift in and out of cells in opposite directions of potassium and to maintain the cation balance. So when we have too much extracellular potassium, this happens to rise with acidosis and vice versa for alkalosis. Remember, the regulatory site for potassium balance is distal convoluted tubule and collecting duct. Okay. Influence aldosterone. So aldosterone stimulates potassium secretion and sodium reabsorption. Okay. So salt substitutes can become kind of popular. They have their highs and their lows, but remember, salt substitutes, in order to make it salty, you got to add a mineral on. Normally that mineral is potassium chloride. If someone has an issue with aldosterone, this is not a safe substitute. Calcium phosphate, as far as how do we regulate those. So 99% of the body's calcium is found in the bones as calcium phosphate. Remember that parathyroid hormone is super important for maintaining these. Parathyroid hormones promotes that increase in calcium by targeting the bones. It causes the osteoclast, the breakdown of the bone matrix, releases calcium into the blood. Kidneys also increase calcium reabsorption and decrease phosphate ion reabsorption. It's really important to know that phosphate and calcium go together, and sodium and potassium always go together as far as yin and yangs together. And then at small intestine, we have the ability with parathyroid hormone and vitamin D to increase our calcium absorption from there. We've gone into a ton about the parathyroid hormone. I want you guys to look at this at your own leisure and really understand it for the purposes of test. As far as calcium, it's really important in blood clotting. We know we need it for muscles. We know we need it for secretory activities. Too little blood calcium causes increased excitability in the blood, leading to into the muscles, causing tetany. Hypercalcemia is heart arrhythmias. Then, as far as anions, the negative charges of our body, chloride is the major anion accompanying sodium in the extracellular fluid, helps maintain osmotic pressure of the blood. And then here's the meat of the matter. It's called acid-base balance. Remember, we need our pH to stay at that nice 7.35 to 7.45 range. Also, our other blood and the intracellular fluid, we want to keep it at 7. So we always remember the magic number of 7. Okay, 7.35, 7.45. And I think above a 7.545 is called alkalosis or alkalemia, which is too basic. And then acidosis or acidemia, it means it's too acidic, under 7.35. How do we regulate these? We have a few buffer systems. We know we took a little bit of time looking at it in the respiratory system. So we have chemical buffers, and this is our first line defense. So our chemical buffer systems are meant to be like to-do, and then our brainstem comes in, acts about 1 to 3 minutes after that, if it's not enough. And the renal mechanisms, even though the kidney is most potent, it requires hours to days to affect the pH changes. So we really need that buffer system to be in place to really make a difference. And chemical buffer systems, so remember, if a strong acid can dissociate completely in water and can affect that pH, weak acids can dissociate partially, and they're efficient at preventing pH changes. So when we put in hydrochloric acid, it's a strong acid. They break up really fast into hydrogen and chloride ions. When we take carbonic acid, which is our precursor in our blood, remember the carbonic acid, the carbonic anhydrase, this can stay as carbonic acid. This can also be a bicarbonate and hydrogen ion. We have 3 different buffer systems. We went over them in a lab really in depth. So we have our bicarbonate buffer system, our protein buffer system, a phosphate buffer system. Bicarbonate buffer system is that bicarbonate, a weak acid, and salsa bicarb. That's a weak base. It helps it's the main extracellular fluid buffer, but also helps in intracellular. With the phosphate buffer system, which is really important in the urine and intracellular fluid. Protein buffer system is really important in the intracellular fluid and the blood plasma. As far as our lungs help regulate our hydrogen ion concentrations. And the lungs and the kidneys work together. They act more slowly than the chemical buffer system, but remember, they're more powerful, okay? When we breathe air in and breathe it out, we want to get, sorry, now I have watermelon sugar high stuck in my head. Respiratory system eliminates CO2, which is an acid. We don't want acid in our blood. That's not good. So we have, remember, this carbonic anhydrase reaction that we can always dissociate a weak acid into what we need it to go to, depending on what our pH is in our blood. So during CO2, unloading reaction shifts to the left. So it means it goes this way. So if we have too much CO2 in our blood, it goes this way. And we have too little CO2, it goes the other way. Simple as that. Remember, partial pressure is what we really look at, not the actual concentration of CO2. So if partial pressure carbon dioxide in blood rises, that's called hypercapnia. This causes the medullary chemoreceptors to respond in the brain, and it causes an increased respiratory rate and depth, okay? Because we're trying to get rid of that CO2. Rising plasma hydrogen ions, so that hydrogen ions causing acidosis, guess what? We're increasing our respiratory and depth too. And that's being picked up by the actual chemoreceptors. Both cause more CO2 to be removed from the blood, pushing the reaction to the left, and which reduces the hydrogen ion concentration. And I'm starting to lose steam, guys, sorry. Alkalosis is the opposite. So alkalosis is too basic. So when alkalosis occurs, we're actually depressing the respiratory center. So we got a lowered respiratory rate and lower depth of how deep we breathe in, causing hydrogen ions to increase. So hypoventilation causes respiratory acidosis. Hyperventilation causes respiratory alkalosis. So when we're all freaking out before a test, we're like, respiratory alkalosis. Take a few deep breaths in and out and get it back down. And that's also why when someone's hyperventilating, they have them breathe into a paper bag because they have to rebreathe that CO2 and bring some balance back. As far as renal regulation, we have if the chemical buffers cannot eliminate the excess acid or bases, then lungs come in. Remember, carbonic acid, if we keep it in our body too much, it's not great. So lungs get rid of the CO2. Kidneys eliminate what's called non-volatile acids. So they're things that are made from our cells. They're uric acid, lactic acids, ketones, phosphoric acid. Uric acid is made from the breakdown of nucleic acid. Lactic acid is from when we are using our muscles. Kidneys also regulate blood levels of alkaline substances, and they renew chemical buffer systems by keeping those ions in check. Kidneys also have a huge part in doing the bicarbonate in the blood. They either resorb it or generate new bicarb, or they excrete it out. And then all imbalances are classified as either respiratory or metabolic. So respiratory acidosis, alkalosis is caused by the failure of that lung system to perform pH balancing. And what we look at is the partial pressure of CO2 to tell us if it's respiratory or not. And then metabolic acidosis and alkalosis is caused by anything else around the body that cause that PCO2 levels in the blood to change. And they're indicated by abnormal bicarbonate levels in the blood. So when we're looking at adequacy of our respiratory function, we're looking at that partial pressure of CO2. The magic number for partial pressure of CO2 is 45. Once we're above 45 millimeters of mercury, we're in respiratory acidosis. Things that cause it's a common cause of acid-base imbalances. And what causes this is decrease in ventilation or gas. So emphysema, all those smoking stuff that's bad for you, you know, that can cause respiratory acidosis, causes that CO2 to accumulate in the blood, and it causes more acid formation. When the partial pressure of CO2 is below 35, then we have respiratory alkalosis. And as I said, hyperventilation is normally the main reason for respiratory alkalosis. So CO2 is being limited faster than we're produced. That's why we have that paper bag to bring that CO2 back in to bring that pH down. Metabolic acidosis is low blood pH and low bicarb. So how do we tell the difference here? So we look at the bicarb and we look at the pH itself, okay? So what happens is that if we drink too much alcohol, we can have metabolic acidosis. We have too much loss of bicarb from persistent diarrhea, we can have metabolic acidosis. We can have accumulation of too much lactic acid from exercise or shock. Ketosis and diabetic crisis, not the same as ketogenic diet. Starvation and kidney failure, all reasons why metabolic acidosis. And there's a lot of questions I've been getting lately about ketogenic diet. It has its pluses and its minuses. Please talk to your doctor about it. Metabolic alkalosis is the pH is rising in the blood, and so is the bicarb as well. So it's much less common than metabolic acidosis. Most likely, if you were to guess at something, if you didn't know which one it would be, you would probably think it's metabolic acidosis. Normally, it's vomiting of acid contents. So excessive vomiting or over ingestion of antacids or taking in too much Tums can cause metabolic alkalosis. And anything blood pH before this below 6.8 can cause depression in the CNS, which is death. pH above 7.8 causes overexcitation of the nervous system and basically respiratory arrest, death. Okay, we always have to keep that happy space of 7.35 to 7.45. So reason why we have these renal and respiratory compensations, we have two different things that affect our blood pH balances, because guess what? They help each other. So if the metabolic acid-base imbalance occurs, then the respiratory system tries to jump into the rescue. If kidneys can't correct their, the kidneys come in and then they try to correct the respiratory acid base. So they always try to help each other. So with respiratory compensation, so the metabolic pH problems is causing cause a change in respiratory rate and depth. And with metabolic acidosis, the respiratory system is compensating by increasing the rate and depth of breathing. So we have higher hydrogen ion levels, and that stimulates the respiratory centers. So anything below 7.35 is considered metabolic acidosis, remember, or acidosis in general. Metabolic alkalosis is respiratory and trying to compensate by decreasing the breathing. So something has happened in the body. Our body is now trying to figure out how to get this basic back down to neutral. We get more slow, shallow breathing, and that allows CO2 to accumulate in the blood and lower the pH. As far as renal compensation goes, kidneys are always trying to compensate for something. So they're always trying to compensate for pH problem caused by the lungs. And what they do is they adjust the bicarbonate levels. So in respiratory acidosis, kidneys will reabsorb more of the bicarb, create new bicarb, or secrete some of the hydrogen ions there. Hypoventilation causes elevated partial pressure of CO2. And then respiratory acidosis with renal compensation is indicated by a low pH, but a high PCO2 and a high bicarb. And we'll go into that in a little bit. And then the opposite goes for alkalosis. And here's the chart in a nutshell. Because I like using this chart because when you get confused, you can just remember. So when we're looking at respiratory acidosis or respiratory alkalosis, first we're looking at the pH. Is the pH too low or too high? Then we know for acidosis or alkalosis. So in acidosis, we have a low pH, which means we have a high hydrogen ion content. But what's also happening is that we have the primary disturbance is that the bicarb has lowered. So that bicarb, if it's metabolic alkalosis, that bicarb isn't there to keep that basic area. And then the secondary response is the PCO2. So if we look here between metabolic acidosis versus respiratory acidosis, they both have low pHs. They both have increases of hydrogen ion concentration. But look what happens here. So the way we remember respiratory versus metabolic is that we look at the arrows, okay? Where they're going the same direction, that's regardless of up or down, they're always going to be metabolic. When they're opposite direction, they're going to be respiratory. And then alkalosis versus acidosis, we're just looking at the pH. Did the pH go up or down? So it's really simple here. If all the stuff that we were explaining before doesn't make sense, then just concentrate on this. Arrows all go the same way, regardless up or down. We don't really count this area right here. So we're just looking at the pH, the bicarb, and then partial pressure of CO2. They all go the same direction. Guess what? That's a metabolic function that has occurred. They go in opposite directions. That is a respiratory issue that has occurred. And that way we could tell if it's being respiratory compensation or metabolic compensation. But you guys are not going to be physicians, so don't worry about that too much depth. Okay. It's been a pleasure talking to you guys. I hope you guys are enjoying your Friday. I will see you guys next week for reproductive. Quiz will be up soon. Thank you.